Now we're going to go over Chapter 6 in R&M, Doppler segmental pressures of the upper extremity. This is the same as our lower extremity on the legs with the arterial machine with the blood pressure cuffs. We'll just do it on the upper extremities on the arms and fingers. So what this is going to do, it's going to identify the presence and severity of arterial occlusive disease. It will provide an objective baseline to follow the progression of the disease process and or the postoperative course. Evaluates the treatment plan. Results usually combined with the Doppler velocity waveform analysis or the VPR waveforms. All right, limitations here. We cannot discriminate between a stenosis and occlusion, and it's hard to localize the area of obstruction. So if you think about it, the duplex, the ultrasound machine, the duplex will give us more of an exact location of a stenosis because you're going to have the image. You're actually looking inside the artery, as opposed to where this arterial machine can indicate a problem, but cannot tell us exactly where it is. It can give falsely elevated Doppler pressures in patients with calcified vessels. Diabetics are typically those patients with calcified vessels. Cannot use on patients with casts or extensive bandages. Can be affected by temperatures. Is sonographer dependent. So we will use the continuous wave Doppler with the arterial machine, the Doppler continuous wave. We get no picture with this, just the waveforms and pressures. Blood is the moving target and the transducer is the stationary source. Depending on direction of flow, reflected frequency is higher or lower than the transmitted frequency. That's your Doppler shift. Your Doppler probe must be positioned with a 45 to 60 degree angle. And you all know this from working with the Doppler arterial machine, that you can find the pulse, but to get the correct waveform, you really need to get it on that 45 to 60 degree angle, which is hard to do, but you guys are doing great. Same position as the legs. Arms are going to be by the patient's side, relaxed. Head may be slightly elevated. I'm okay with you guys, coming up a little bit on an angle, but a real patient should really be laying down flat. You're going to place the cuff snug on the upper arm and forearm. The bladder of the cuff should be placed over the artery. Just like on our legs, you're going to place the bladder of the cuff over the artery. The upper arm pressure is obtained for brachial artery, forearm pressure obtained for radial and ulnar arteries. You can go on page 83 of R&M. You can see an example of this, of how we will put the cuffs on the patient. So you can see the bladder is over the artery and where we will put the probe. So it is okay when you're getting the brachial artery pressure. You can listen to the artery at the AC. You can listen to the brachial there. You can listen to the radial artery or the ulnar artery. When you're getting ulnar and radial pressures, for ulnar, you need to come on the lateral side, down by the wrist. For ulnar, come on the medial side by the wrist. For waveforms, we will get subclavian, axillary, brachial, radial, and ulnar. This is just for Doppler velocity waveforms. We won't get pressures at all these places, just waveforms with the continuous wave probe, where you take the probe, you're going to come to the clavicle, get a subclavian, you're going to want them to be triphasic all the way down, move it to the axillary, brachial, radial ulnar, just as we did with the continuous wave Doppler probe at common femoral, popliteal, DPA, PTA, okay? All right, this is important. This will be on the quiz, so pay close attention, please. If there is greater than or equal to 15 to 20 milligrams of mercury difference from one brachial pressure to another, the lower side would suggest a greater than 50% diameter reduction of the subclavian artery and or vessel underneath the cuff. So again, if your right brachial pressure is 120 and your left brachial pressure is 60, that should alert you that there is a possible likely problem on the left subclavian to brachial area. A decrease in blood pressure between the upper arm and forearm should not exceed or equal to greater than 15 to 20 millimeters mercury. The vessel with the lower pressure may be obstructed. Okay, so now this, if your upper arm pressure is 120 and your lower arm pressure is 50, there could be a problem with your forearm artery. Okay, Allen test. Page 84 on R&M is where I am. I believe that St. Joe does these. They were, as of last year. I have not heard a follow-up, but I want you to pay close attention to this because some places may be using this. And the reason we're going to do an Allen test is if a cardiothoracic surgeon wants to take the radial artery to use it for a bypass graft in the heart, or a vascular surgeon or surgeon would want to use the radial artery for dialysis. Okay, so again, patient needs an artery for another area in the heart or needs it for dialysis. They're going to check before they will actually remove the radial artery on the patient. They'll remove it, but they need to check and make sure that the patient will be okay without the radial artery. So this is pretty cool. So you're going to check the patency of the wrist arteries. That's your goal. By patency means check to make sure that it's open, patent. And you're getting good blood supply to the fingers. And again, useful in determining hand viability of the radial artery if the radial artery is to be removed for use as coronary artery bypass graft or dialysis. So you want your arm to be in a relaxed position by the patient's side. The head can be slightly elevated. You are going to feel the radial artery and apply compression. So you need to compress really hard all the way to occlude it. Smash it down so there's no pulse, no blood's getting through. While you're doing that, while you're compressing the radial artery, the patient is going to clench their hand into a fist for about a minute. You keep the radial artery compressed and the patient will relax their hand. When the hand is clenched into a fist, the hand should lose color and turn pale white. When the hand is relaxed, with you still pressing on the radial artery, the hand should come back to normal skin color. Now, this is a little bit hard to say what's normal, what's abnormal skin color. So what you can do instead of saying, oh, it was pale and it came back to normal color, because that's a little subjective. You can put the PPG, the light sensors that we use on toes and fingers, remember those on the little clips? You can put those on the finger or fingers while you're compressing the radial artery. So you can press the radial artery and see if you're still getting a pulse in the fingers. If you're still getting a pulse in the fingers, that means it's okay to take the radial artery. The surgeon can take the radial artery. The hand will survive, and the ulnar artery is providing enough blood flow to the hand. And ideally, the radial ulnar, the ulnar artery is the predominant blood source to the hand. So it should be okay. However, we do this test just to double check that. Okay? So that's it for this week. I do need you to please review these PowerPoints. Please review and read the chapters for this week. Next week, we will have a quiz. We will have a quiz next week in class. It will not be open book. I'm talking about on Wednesday, October 8th, 8 o'clock, we will have a quiz, 25 questions in person. I want to review real quick for that. So what I want you to make sure you review after you read the chapters we've gone over and reviewed these PowerPoints multiple times, pay close attention, be sure you can label arm anatomy and talk about it. Know what a normal upper extremity waveform would look like on Doppler and duplex. So remember, we want upper extremity arterial waveforms to be multiphasic, not monophasic. Monophasic would be abnormal. We want them triphasic. Familiarize yourself with Steele syndrome and Allen test, brachial reactive testing. Know about differences. What does it mean if you have a difference in blood pressure, brachial, side to side, or on your different arm levels? Dialysis fistula. Know the types. Brachiocephalic or a semino, which is a radiocephalic. If I gave you a picture of that, could you identify? You would know because I'm going to show an artery in the upper arm brachial to the cephalic vein, a connection, or lower arm radial to cephalic. Those will be the two main types. When we look as sonographers, when we do an ultrasound on a dialysis fistula, what are we looking for? We're looking for patency. Is it patent? Is it open? Is there blood flowing through it normally? Is there stenosis, which is a blockage, would give us a very high velocity? Is it occluded, which means clotted off, no blood's moving through? If a fistula is occluded, the patient cannot receive dialysis. So that's very important to let them know it's occluded. You also wouldn't feel that thrill when you put your hand down on the arm of a fistula. You will not feel a thrill. We also look for aneurysms. They get really aneurysmal, which is just a big dilation. Let's see. Hypothalamus hammer syndrome, know about that. If you know all of those, review those heavily. You should do fine on the quiz next week. Again, it will not be open book. It will be in person at 8 o'clock, 25 questions. Okay, if you all have any questions this week, you can text or email me. Have a good week.